Hello, Dr. Sridhar. It's a pleasure to interview you for our initiative called SIREO. SIREO is an initiative for reaching out to the public by actively engaging academia, industry, and the healthcare sector so that we can reach out to people in effective ways about how important science utility and education is. So, could you just introduce yourself to the audience?
Sure. My name is Sridhar and I work at the St. John's Research Institute, and I have been here for the last decade, and by training I am a physician scientist. I did my medicine initially, followed it up with a PhD, and after I got back here I have been working on breast cancer for the last 10 years. But I must hasten to add, I am not an oncologist, and I am a neurologist by training, and I am here in my role as an academic researcher into breast cancer.
Could you briefly, in 2 sentences, tell us what you do in your lab?
Well, our lab is quite different from most other labs. When you say a lab, people have a certain sense of what goes on in a lab. Right? They imagine scientists trying to understand things, and that part of it is true about our lab as well. However, if you were to take a pure science place, and the Indian Institute of Science would be a good example, the approach to the understanding of a problem that is used at the Indian Institute of Science versus the way we work in our lab has many similarities but some important differences. First off, we are located on a medical college campus, and we started this activity from a very different motivation. When we started this work, we wanted to actually try and understand those aspects of the disease biology that made a difference to patient care. And one of the critical choices that we made when we started our work was to focus on the specimen, that is the human disease specimen itself, the breast cancer tissue. So my laboratory has, for the last 10 years, used as its central material, so to speak, the breast cancer specimen itself. The second part, which we are very different in our lab from almost all other labs, is that we wanted continuity of contact with the patient from the very beginning. So we did what in technical parlance is called a longitudinal cohort study, in which patients are enrolled into a study at the beginning of it, and then you stay in touch with them over long periods of time. So we have built a breast cancer cohort of 446 women who were diagnosed with breast cancer, and for the last 10 years my lab has been involved in staying in touch with these women as they went through their disease, as well as analyzing their specimens in our laboratory.
Are you aware of any other groups that are doing this kind of a study in India?
Yes, actually we are not the only group. In fact, I would say that almost all hospital-based research groups, be it the Adyar Cancer Institute or the Tata Memorial Hospital, have a very similar approach to research. And most importantly, I think this approach got a great fillip about 10 years ago, when the National Institutes of Health in the US set up what was called the TCGA. The TCGA stands for the Cancer Genome Atlas, and not coincidentally, those are the 4 bases that make up the DNA. And they approach this exactly the way we have structured our work, in that patients were recruited, their specimens were collected, they were followed up, and then these specimens were interrogated using the techniques and the tools of modern biology.
So how do you think this is significantly different from the kind of research that happens in a so-called lab? And how do you think it matters, especially in India?
The significant difference, I would say, comes from the typical motivations of a researcher in a pure science lab. There, most often the researcher is motivated by trying to understand how that process happens, so carcinogenesis itself, or how does the tumor behave, right? So they're propelled by trying to understand the fundamental biology of that condition. Whereas here, we were propelled to try and see if, based on the alterations we found in the breast cancer tissue of women who did well, quote unquote, meaning people who did not succumb to the disease, versus people who unfortunately succumbed to the disease. Were there changes in their tumor? If we knew of these changes at the very beginning, they would inform the physician taking care of them, make better treatment decisions. So it was actually one of motivations, in short. We were motivated by trying to aid the treating physician make more appropriate decisions, and a fundamental lab research in a place like IISc is motivated by trying to understand the biology. Both are important, they're different, right? And in India, while both sorts of researchers and both sorts of researches have been done in the past, the uniqueness, if I were to say, of our approach was we attempted to and succeeded in staying in touch with exceedingly large proportion of the patients who were recruited, 96 to be precise. So that is 96% of all women who were enrolled into our cohort. We stayed in touch with them over a period starting from 2008 to 2017. To the best of my knowledge, that proportion, 96, is an unprecedented proportion for such a long time in the context of breast cancer in our country for these numbers.
So now that you are, compared to the other researchers, I must say that your research is close to the bedside rather than the bench side. So you would be a better person to tell me how important is a centralized scheme for breast cancer necessary in India?
That's a tough question, because let me try and understand what you mean by centralized scheme. Can you elaborate?
So there are a lot of other countries who have adopted large-scale screening programs for different diseases, especially for cancer, because early diagnosis is a very good prognostic factor rather. So one of the basic things they do in a screening scheme would be to have to be screened for lumps. So if we can start off from there, we can rather pick people earlier. So in that way, how?
Absolutely. No, so I let me clarify. So what you have said is true. First, again, I would like to say the work that we do does not address that aspect of breast cancer,
Yes.
because we have recruited into our cohort women who were already diagnosed with breast cancer.
Okay.
So if I were to answer your question, should screening be the highest priority for the early detection of breast cancer? That's an absolute no-brainer. I think if India needs to focus on a single aspect of breast cancer, and this doesn't require any research, right? It just requires implementation. Screening would do more than all the other aspects that we look at put together. Absolutely not. There is an interesting question though that it brings up as an aside. Who should be screened? When should they be screened? And how often should they be screened? And these questions have different answers based on the population. They have been answered with somewhat good data and rigor for countries that have nationalized health schemes like the NHS of the UK or Scandinavia, where there's very good longitudinal data about how many cases they had before screening programs were implemented, and then how many they detected after, and actually more importantly what happened to the mortality. Did screening reduce mortality? Well, ultimately, if you do screening and it doesn't reduce mortality, it doesn't matter from the point of view of a public health. So in India, the curious fact is that the age of breast cancer diagnosis is about a decade earlier than what is encountered in Western advanced economies. So US has a median age at first diagnosis of about 60 or 62, and in India it's 50. So if half of all women who are diagnosed with breast cancer are under the age of 50, then it makes no sense to start screening after the age of 50. So the only thing that I can say based on our data is that screening programs, if they are nationally implemented and widely done, then the age of screening probably needs to be earlier in India than the recommendations made by Western societies.
With the kind of facilities that are available for diagnosis and treatment in India, so what do you think needs more improvement? Penetration or betterment in the technology and research that is necessary that goes into diagnosis and treatment?
Again, I'll take your question in two parts and I'll take it at a slight distance.
Yes.
First off, like I pointed out to you, though I'm a physician by training, I don't treat breast cancer patients, right? But so let's look at just diagnosis for a start, and let's just stick to diagnosis. Very clearly, there is a urban-rural divide. Okay? So these facilities that are necessary for first diagnosis, which is typically a mammogram, are available easily in large cities, somewhat in tier 2 and tier 3, and not at all in the rural setting. Right? So that is the first modality for the diagnosis of a breast lump as probably malignant. Right? But it can only be confirmed by doing what is called as a biopsy or tissue examination, histopathology. And that capability rests in any center that has a trained histopathologist who can perform the biopsy and then look at it. Actually, no newer technology is necessary for doing the diagnosis of breast cancer, right? So people think that more technology will make diagnosis better. No, actually we have everything we need to make a diagnosis of breast cancer with significant certainty and very little ambiguity. Now, if you go past the base or core identification of a tumor as breast cancer, but now start asking deeper questions, saying that, okay, but breast cancer, does it come as a single type or are there multiple flavors? The answer is that breast cancer is actually not one disease anymore. Breast cancer at the very base is of two types. Tumors that express the estrogen receptor, that is the receptor for the female sex steroid hormones, and tumors that don't express it. So you can be either estrogen receptor positive or estrogen receptor negative. In addition, there is a certain cancer on switch, if you want, that is the turning on of an element within a cell that makes that cell divide continuously. And the protein that does it is called HER2 in the case of breast cancer. That's a growth factor receptor. So if you have an amplification of that particular growth factor receptor, your breast cancer behaves in a certain way and it needs to be treated with a certain set of reagents. All of these modalities are available in all standard laboratories, histopathology laboratories that offer these specialized services. And not every place needs to have it because the block can be sent out and you can get the diagnosis. But if you go one step further and say, yes, I've got the diagnosis of breast cancer, I know whether it's ER positive or ER negative, I know whether it's HER2 positive or HER2 negative, can you tell me even more that can help the doctor tailor the treatment to my particular tumor, what is now fashionably termed personalized medicine? Then diagnostic modalities are actually much more limited in their availability, and the development of these methods have to be taken up by probably tertiary care centers and offered to people. But it is not the core essential testing. All of the technologies necessary for the diagnosis of breast cancer are available, well tested and foolproof.
All right. So, could you comment regarding the treatment?
I would rather not,
Okay.
because I know how they're treated and we follow them up.
Mm-hmm.
It's not in my purview because I'm not an expert on it. All I can say is it's multimodal, the treatment is multimodal, and it incorporates surgery, radiotherapy, chemotherapy and hormonal therapy. A given patient may get one or more of these modalities depending on the age, stage and type of tumor. Okay? But again, the knowledge and the capabilities necessary for making these determinations are fairly widespread in all tertiary care centers, medical colleges, even taluk level places would have people who understand it to refer them to the right places. And it has become more and more common now to do it in the context of what are called MDTs, multidisciplinary teams, that have a surgeon, a radiation expert, a medical oncologist who can prescribe chemotherapy or hormonal therapy, and in addition now psycho-oncology and nutritional support. So it is a multidisciplinary team that evaluates that patient, figures out what is most suited to that person's type of disease, stage of disease, makes the recommendation and works with them to provide them the best therapy available.
So you were talking about how your research is in terms longitudinal. And also there are other groups who are doing such kind of research. Do you think whatever research at present that is happening is enough, or we need more people, or there needs to be more rigor into whatever the present group of people are doing?
There are many interests. Obviously, research by its very nature, it begets more questions and leads to more research.
Mm-hmm.
So if you were to ask the question from the point of view of patients and what needs to be done for an average patient with breast cancer, then I think that we have enough information to work on and provide world-class care in India. Yet there are many, many interesting questions. So there are questions like the demographic I told you. Why is it that younger women in India are diagnosed with breast cancer? The glib answer is because we are a young society, right? So if you take the US population demographic and plot it, you'll find that the median age of women in the US is about 38 or 39, right? If you look at it in India, it is 28 or 29. So we are on average, our demographic is 10 years left shifted. So there are a large number of young women here, and so you have these young women develop cancer, though the frequency of the cancer developing in young women is much lesser than that it is in older women. Right? That's one answer. But supposing you try and match and say, okay, I'm going to take 100,000 young women who are between 40 and 45 in India, and then I'm going to take 100,000 young women who are between 40 and 45 in Scandinavia, and see what the cancer rates were in them. We don't have the answer to that, right? So if that is more here, then it may be an interesting question to follow. The other very interesting observation people have made is younger women tend to have more of what I refer to as triple negative breast cancer, and so that form of breast cancer is interestingly more often encountered in Indian women as well. So the question is, does that have a genetic basis, or is that to do with the reproductive behaviors and cultural practices like breastfeeding or not breastfeeding? Is it related to that? And I don't know, I could add another thing about now, since people are starting to recognize that there is a genetic component to cancer, or what are called as familial or hereditary cancers. So hereditary breast cancer got, I think, far more press after Angelina Jolie went public with the fact that she had inherited a gene, and that was the reason she decided to do what she did. Now, that particular gene, BRCA1, has gotten a lot of press and attention, and there are questions as to whether the prevalence of those specific mutations are higher in Indian women or lower in Indian women, because BRCA1 mutations lead to the type of breast cancer that would be called triple negative breast cancer. But I want to emphasize one point here, which I think a large number of people, including physicians, don't make very clear. By and large, breast cancer continues to be a sporadic disease. It has elements of genetic alterations that happen in somatic tissues, that is, tissues in your body that do not contribute to the making of a baby. The cells that go on to making of a new baby are called the germline tissues. But these mutations or alterations happen in somatic tissues. So most cancer is still sporadic, 90%. So all of the hereditary and familial forms of breast cancer put together in a clinic, a large clinic that takes care of thousands of patients every year, would not be more than 10%. 90% is not because of something that you inherited from your mother or father. There's a second misconception. Many women and some doctors even look and ask for breast cancer only on the maternal lineage. Did your mom have cancer? Does a sister have cancer? Right? And actually this gene and the mutations that are there in it are not restricted to the sex chromosomes. They're actually on autosomes. So it may be your father's sister who had breast cancer. So what you need to look for is a family history of breast cancer on both sides. And the third point, which is I think the most important point, is should there be a genetic predisposition, it tends to manifest early in past generations. So if your granny developed breast cancer at 70, it's highly unlikely that it is some familial predisposition. Whereas if your aunt had breast cancer at 45, then that ups the ante for it being, there being a greater likelihood of it being due to inherited predisposition. But all said, I want to repeat, inherited predispositions don't account for more than 10% of all breast cancers.
I have this last question. I want you to tell people more of if people getting enrolled into such longitudinal research programs help treatment.
In our case, we were extraordinarily fortunate, and I'm quite surprised when we explained to the patients as to what this whole project was, and we told them explicitly that there was little or no likelihood of them deriving any benefit from the research we were doing. 95% of all women consented to being in the project. So what it told us was that people actually were being very altruistic. They were not asking us as to what our research would do for them. When we told them that we will help, and all we said was that this research might help us come up with more definitive ways of testing breast cancer for specific treatments in the future, they were more than happy to participate. So I don't think it's ever the challenge of getting them to participate. I think it is the effort necessary for us to explain it to them, and two, I think to be honest, right? If we're honest up front, saying that you're not going to benefit from it, I think most patients who are in that position, vulnerable position, are incredibly magnanimous. That was our discovery.
Fantastic. Do you have anything to add more to the discussion we have had?
In terms of this form of research, so there are two types of research that have received a lot of attention: the fundamental research that happens in research institutes, and then what are called clinical trials. And this sort of research, which is clinical research, with a long-term follow-up and correlating what are called outcomes, that is clinical outcomes, to biological alterations, I think needs to be taken up on a larger basis, not necessarily for breast cancer, but for other forms of disease. And there was some reluctance to do this because of the logistical difficulties and the nature of the project being so long-term. And I think for us the gratifying part is that having succeeded to a measure in doing this, we recognize that it can actually be expanded not now just to breast cancer, but other forms of cancer, and not merely to cancer, other forms of chronic diseases, be it degenerative diseases, other forms of diseases. Because all diseases have a genetic component and an environmental interaction. Right? So it is the juxtaposition of that particular genetic predisposition and the particular environmental history of that person which leads to the manifestation of disease. And so I think longitudinal studies, cohort studies, help you to explore that in a very interesting manner.
Thank you very much, Dr. Sridhar, for taking our time and talking to me.
My pleasure.